Um, well, good morning, everyone. My name is Helen Brown, and I'm the CEO of Mental Health Reform. I am delighted to welcome you all to our first webinar of the year, Sharing the Vision, the Journey So Far. It's absolutely fantastic to have so many attendees here today, including our members in the voluntary and community sector, people with lived experience of mental health difficulties, clinicians, policymakers, and colleagues from the HSE. It's your presence that really reflects the shared commitment behind this national policy. For those of you who may not be familiar, Mental Health Reform is Ireland's National Coalition for Mental Health. Our vision is an Ireland with accessible, effective, and inclusive mental health supports for everyone. As a coalition, we bring together over 80 member organisations and thousands of individual supporters, providing a unified and powerful voice on mental health issues. As many of you know, Sharing the Vision is Ireland's 10-year roadmap for transforming how mental health services are delivered. This policy recognises the voluntary and community sector as a core pillar of the mental health system. So this webinar will take a closer look at the impact of Sharing the Vision in the voluntary and community sector and what it means for people who access mental health services. We're now moving into a crucial phase with Sharing the Vision with the 2025-2027 implementation plan, which focuses on meeting people where they are, integrated community supports, early intervention and prevention, digital innovation, and a stronger emphasis on lived experience. As Sharing the Vision is translated into practice, it is critical that we continue to strengthen the role of the voluntary and community sector through effective partnerships, meaningful collaboration, and also sustainable funding. Today's webinar is an opportunity to reflect on the progress so far, to explore developments, and to hear directly from those shaping and delivering this work every day. So I just like to say a big thank you for being part of this conversation and for the vital role that each of you play in building a mental health system that's accessible, person-centred, and grounded in community. I'm now going to look at the help that anyone might need if there is anything in today's webinar that you might find distressing. So please be aware that there are supports available. You can visit the HSE webpage, yourmentalhealth.ie, which has a full range of supports and services available. You can also contact the Samaritans for free on 116 123 or email joe@samaritans.ie. There's also the Text About It service for a free anonymous 24/7 messaging service, which provides everything from a chat to immediate support for your mental health and well-being. I'm also delighted today to launch our new Sharing the Vision animated video, which was co-produced with experts by experience from the Sharing the Vision reference group. This explains what the policy means for people accessing mental health services. This video is available to watch on our website in 12 languages, and I'm delighted to share that now.
In Ireland, 1 in 4 of us can experience a mental health difficulty. For some, it's brief and manageable. For others, it's lifelong and deeply challenging. No one should feel shame for their experiences. Mental health affects us all. Sharing the Vision is Ireland's national mental health policy, a guide to how we can build a kinder, more connected system of care. A human rights-based approach shaped by collaboration and peer support can make sure that all of society is reflected, including people from marginalised communities who have too often been left behind. At the crossroads, we're recognising the strong connection between life circumstances and mental health, how education, employment and housing shape the road ahead. Social prescribing is linking people back to their communities, and Solace Cafes are providing free out-of-hours supportive spaces. Child and youth mental health services are growing stronger, creating pathways for early intervention and positive mental health. Digital tools like CBT programs and the Navigator app are signposting help and support, bringing care closer to people's lives. Specialist clinical programs are expanding, including eating disorders, ADHD, dual diagnosis, psychosis, and perinatal mental health. A new national mental health research strategy is our compass to guide and advance mental health research. In Ireland, progress matters, but real change takes time. There are blocks in the road where too many people are still waiting. Gaps in services create opportunities to make care more consistent across communities. Sharing the vision is the journey we take together to challenge stigma, where people feel seen, heard and respected. That's where our journey begins. This video was shaped by lived experience, because real vision begins with those who have lived it. Nothing about us without us.
Thank you. So I'd like to take us through now the agenda for today, for the rest of this morning. So at past 10, so coming up soon, we have the policy implementation learnings, challenges and opportunities discussion, and that will take place with Catherine Brogren, with myself and with Sean Blake. We then have an update on sharing the vision in the voluntary and community sector with Roshan Farrelly, and a panel discussion and question and answer session, followed by closing remarks and the opportunity for questions. So joining us first, I'd like to bring in Catherine Brogren, Chair of Sharing the Vision National Implementation Monitoring Committee and CEO of Suicide and Survive. Catherine has a wealth of experience in the mental health sector and has been central to guiding the policy's progress. So welcome, Catherine.
Hi, how are you, Helen?
Yeah.
Thank you so much for inviting me on today.
Well, it's absolutely fantastic to have you, Catherine. And my first question really looks at the role of NIMIC in steering and monitoring the implementation of sharing the vision. So could you talk about how this works in practice, about NIMIC's central role in monitoring the implementation, and the importance also of cross-sector working in delivering sustained change?
Okay, so I suppose what I was going to start about first is that this is the journey so far.
Yeah.
And it's not just the journey so far with sharing the vision. It's been a long lifetime journey for myself in my own career over 46 years. And although we sometimes look and say we haven't achieved a lot, if we do stop and think, and particularly in the last number of years, particularly in the last, say, 5 to 7 years, we can really see that we've ramped up the changes that are taking place.
Yeah.
And I think the main reason that has happened is because the realization that without the inclusion of the voice of lived experience in everything that we do, and that includes the family members, supporters, and our service providers working together, that we will not get the change we want. So I kind of thought, Helen, when we were discussing this the other day, that, you know, a lot of viewers may not be aware of, you know, they've heard of NIMIC, but what is it? What does it do? Where does it fit? So there's 18 members on the group, soon to be 19, and I'll tell you about that shortly. We come from various different backgrounds. So we come from lived experience, we come from a HSE perspective, Department of Health, psychology, psychiatry, nursing, social work, representative bodies, OT, and of course the community and voluntary sector. We're all appointed by the Minister for Mental Health.
Yeah.
And in that appointment, that makes us her representatives to ensure that the recommendations are implemented and to oversee that process. So when the people are appointed, they're not there for 10 years. There's a 3-year rotation or a 4-year rotation. So when you were asking me about how are things sustained, that's one of the ways. So at any one time, we'll only have a third of the representation leaving, with new blood coming in then at every 3 years. So, for example, we've got a new number, there's 7 people joining in the next couple of weeks. So the people rotating off have 3 to 4 years experience of being on NIMIC. They will meet with those new people and be part of the induction so that we don't lose any of that experience and any of that learning. And as well as that, they'll also meet, you see all of the documents that are produced, you see all the specialist groups, you see all the information that comes from that. And where that doesn't happen just by itself. So as NIMIC members, we're volunteers there. So we need support. So the HSE and the Department of Health Secretariats are amazing in providing that support. And again, the joined up piece with the reference group. So the reference group are a really important advisory group supporting NIMIC in what we do. They bring that perspective of the living experience and family member supporter experience. They give us guidance. They share advice with us. They also provide feedback. And it's from that specific perspective that sometimes when we're thinking about all of the different operational aspects of services and that on NIMIC, we can miss that. So they keep us in step in relation to that. And we take on the feedback that they bring to us, and that's incorporated into the reports that come out biannually. The biggest thing that makes a difference for me is communication. And I think if you look across any time anything's have failed, it's because there's been a break somewhere in communication. So communication has to be an underpinning principle that continues to strengthen and evolve as part of this process. We're really fortunate that we have the Minister for Mental Health as also the Government Chief Whip. So that actually gives us a seat at cabinet tables. And it means that every day in the government, the voice of mental health can be portrayed through the Minister for Mental Health. In my role as the chairperson, I get to meet the Minister regularly. I get to talk about the progress we're making, but I equally talk about these are the challenges, these are the blocks, these are the barriers that are impacting on sharing the vision actually being implemented. And that without specific enablers, we cannot implement the policy in the 10 years that's prescribed. The Minister can go back then and advocate. And she has been a very, very strong advocate for us. And we've seen in the last 5 years that incremental build on the resources, bringing it somewhat back towards where it was when I started in mental health, which was at 13% of a budget, rather than where it is. But we are growing and we are developing. And we're also learning how to use what we have in a much better focused way. We've also, through our conversations, adapt gaps that exist on the NIMIC composition. So, for example, there wasn't a lived experience perspective on NIMIC because of the reference group, but we felt, hang on, there's a piece missing here. So in 2024, we brought that lived experience onto the NIMIC committee. And this, what I was saying, we're having an extra person coming on now in the next couple of weeks. The extra person is going to come from an NGO perspective, and the NGO perspective from a diversity inclusive. So that really, really makes it more specific to the membership being completely inclusive. So that will continue to evolve because as we make the changes, as we see traction happening in various areas, it'll change the composition of the group, and rightly so. So a big positive that happened in July 2025 was the establishment of the interdepartmental group. And you spoke about that in the video. It's about all of us working together. It's about housing. It's about education. It's about something to do, someone to love, someplace to live. All of those things that are so important. And what their function and role is that they need to start aligning their government programs to the recommendation sharing the vision. And part of the Secretariat from NIMIC sits on that group. And Philip also fits on it and brings back what's happening there. But we've also extended the hand to them to say, if you are leading on a specific project, if you need advice, come to us in NIMIC, do a presentation as best we can. But we'll also listen to their perspectives as well and the challenges that they're experiencing. So that brings me to kind of winding up this around what we're doing and how we're doing it. And it really is that we all come from our own perspective. And that's really important. And we all bring an expertise. And this is why the process is so rich. It's because we have one shared goal. No matter what perspective we're coming from, we have one shared goal. And that goal, through shared leadership and collaboration, we have and will continue to drive the implementation of sharing the vision.
And Catherine, that was such an insightful insight into sharing the vision and the developments that have taken place over the years. And we know also that there are some system-wide challenges in delivering sharing the vision. For example, workforce pressures, rising demand, and major reforms such as the HSE restructuring. So how do these shifts in the sort of wider health landscape shape delivery, and what opportunities or risks do you think they create?
Yeah, I mean, if you look at the new restructuring, and let's face it, we all had concerns around it from a mental health perspective specifically, because we're just a small piece of the jigsaw that is integrated healthcare services. And this is a new way of working, and the new structures are still evolving. So when that started to take shape, and through discussions with the minister, she responded by reviewing the membership of the NIMIC to see who we have representing that's aligned to the new structures. So given that, she went out to the system, and we now have the regional executive officer. We also have an assistant national director for integration and access. And we also have an integrated healthcare manager with specific expertise in mental health joined the NIMIC in November of 25. Now, when you do join it, we have to make sure that this has to be aligned to continue to drive the implementation of sharing division, but also marrying that with the new structures. So that's one piece that has been done around that risk that was presented. The other has been through the appointment of the lived experience and having more diversity on the NIMIC. We can make sure that we are completely embedding and keeping at the center the voice of lived experience to inform the NIMIC around what we're doing, so that we can offset risks as they and more importantly grab opportunities as they present themselves. Big thing that we started to before the structures even were spoken about was that instead of having meetings in Mezzanine Plaza in the Department of Health as an NIMIC, we took them out into the regions, because I think we were talking about it earlier around seeing policy being translated into practice. When we're sitting as a NIMIC, it's so important that we know, well, what's happening on the ground?
Of course.
Where are the areas of good practice? What innovations are taking place out there? How are we seeing co-production in practice? And absolutely unbelievable going out to the 6 regions. And we only had our last regional meeting there in November of last year. And each of those meetings built upon the expertise and the information and the thinking of how NIMIC applies the process into the work that we need to do to implement the next phase of sharing the vision. And they were really, really upfront and honest around the challenges, the drawbacks, the progress. But what really, really struck me and the NIMIC members was how they found solutions. Because they really, really care about making changes that make services better for people who need them. And the biggest piece that we found is that where co-production was spoken about, did people really understand? Do people really understand? But we can see a change in that. We can see more meaningful co-production taking place, not that tokenistic co-production. We can see that people are beginning to understand the absolute importance of the lived experience voice informing service change. Then again, we had the launch on the 15th of October last year of our very first Lived Experience Awareness Day. And it's, you know, the first of its kind to happen. And really, I know that was the launch part, but it highlights that whole piece around the importance of lived and living experience, and also gives us now the opportunity to grow that. I think key to implementing anything within the new structures is going to be building capacity, and building capacity of that expertise across all services. And that's not just within the mental health service. We need to look upstream. We need to look at the parts of sharing the vision around promotion, prevention, inclusion, accountability. So we need to have capacity building across all of those areas. And it's also worth telling you that, you know, we do the analysis reports with the reference group that's submitted to the minister twice a year. And in that, we can be very critical. We highlight the successes, absolutely, because we need that, because we all need hope to make it, you know, to show that we are making changes. But we also voice our criticisms around the challenges of particularly recruitment, retention, having proper facilities, you know, so being very strong on those. And I know that this has a huge, huge knock-on the timelines that we set in relation to addressing all of the recommendations. There's interdependencies between them all, and we can't do it with a cog missing. And but having said that, there has been great progress in the last few years of delivery of the services, and particularly in relation to the development of the national clinical programs.
Great. Well, thank you so much, Catherine, for sharing that. And we can really see the impact that sharing the vision has for people accessing mental health services and for their families and supporters. And I'd just like to thank you for being part of the conversation today. And I'd also now like to introduce
Helen,
our next...
Sorry, just before that, Helen, do you mind, just in relation to the implementation plan for 2025-27? I know one of the things you were asking me about when we had a discussion was just, and I'll give you this briefly, is just in relation to what are the differences. And the biggest difference that took place between the first implementation plan and the second implementation plan was the level of consultation that happened to develop it, the inclusion of all the voices. The recommendations are now not being seen as one at a time. They're being seen as groups and interdependent. They're also being mapped against the measurable outcomes and the policy priorities. And they're being linked specifically to the transformational program within the HSE of, you know, the guidance for the operating framework for mental health services, the guidance for community mental health teams, and the implementation of the children and youth action plan. And the community and voluntary sector are so integral to that. And I think you mentioned it there earlier in relation to, without them, there'd be spokes missing from the wheel. We'd have a lot more challenges, a lot more blocks. But what you can see that has happened in recent years, particularly in the last 24 months, social prescribing, solace cafes, the digital support through the community and voluntary sector. So we have our online platforms of the Navigator app, our Silver Cloud, or My Mind, and that's just mentioning some of them. And I thought it was really, really important to say that what we want people who use our services and their family members to know that we want you to tell us, is this working? We need to hear your voice around that. For me, how I know it's working is when I go to any service, primary care, secondary care, and to hear the word hope being used, to hear the words recovery is possible being used, to see our services focused as recovery orientated services, that the first day you go in is talking about your plan to leave the service and to go back to your community and to be totally integrated and have a life that you want, even with the limitations of mental health challenges. Sorry, I just wanted to get that piece in.
No, that's absolutely fantastic. And I really appreciate you sharing some of the shifts in emphasis that have taken place over the years as well, and with the new 25-27 plan, and how kind of inspiring that is. And it's really useful to have heard all these insights that you've given today. And I'm sure that people will have follow-up questions as well after the session, which we can share and discuss. So thank you so much, Catherine. I really appreciate your time today and for sharing your expertise and the progress of sharing the vision so far. This brings me on to Sean Blake. So I'm also delighted to welcome today Sean Blake. Sean is the Shine Ambassador, member of the Voice Platform, a lived experience expert and member of the NIMIC Lived Experience Committee. So Sean brings invaluable insight into how policy translates into real world impact. He seeks to normalise everyday conversations about mental well-being and increase awareness of eating disorders. So, Sean, thank you so much for joining us today. And I just wanted to start really by looking at your own lived experience and what support you found most meaningful outside the health system. What kind of community-based support did you find most meaningful?
Well, for me, again, the voluntary sector was vital.
Yeah.
So Bodywise, for example, and Shine. So Shine has opened me to so many things. I've met so many people who understand, they've lived experience, and it's also given me the platform to speak and to to share my lived experience and to use the voice that I've been hiding for my whole life. So yeah, an incredible opportunity. So that's been so important, because when you come out of a hospital setting, you need the support. Ongoing support is vital. Like my family structure is also important, just to to keep an eye, to make sure I'm okay. But when I went back to work, I was out of work sick for 2 years. But being able to go back in a reduced way, and just simple little things like they understand, sick certs and things like that, not needing them every week, and it's just those kind of supports that really put you at ease. But again, mainly just being able to link with community and to have somewhere to go, someone to talk to. It's just so important. Also, we can't underestimate how having that lived experience respected is at highest levels. I had the opportunity to meet Minister Butler, and that was at my own request. So it's just an example of how feeling your lived experience is appreciated, and a genuine want to kind of hear your story and to help. So there's so many things. Like being here speaking at the moment is massive help to me, because as a person who would have lived a life of low self-esteem, being given the opportunity to do this really it's contributing so much to my recovery. And again, it's also helping other people, I hope.
And Sean, thank you so much for sharing that. And I know that we discussed earlier this week really about stigma and self-perception. And I wanted to ask you how you feel that this national policy can help shape kind of societal attitudes, looking at that stigma and self-perception.
I think there's so many there's great opportunities to do this here. I was actually at an event in October, the Brain Innovation Days in Brussels, and I was talking to people from all over Europe, all over the world, and they were so surprised at the lived experience that we use over here, and we don't give ourselves the credit, I think, sometimes for that. And I think lived experience really needs to be kept embedded in it, particularly in national policy. I think awareness and education is where it needs to start. At every level. I mean, from education to teachers to people in social clubs, sports clubs, just to destigmatize language. I mean, I find things like schizophrenia, psychosis. We need to do so much work on that, because there is not a real understanding of it out there. We need to take that fear out of that. The stigmatizing language you hear around things, it's just shocking, really. I think if we start that at a lower level, if we get people to understand what it truly is, simple things like medication stigma. People are afraid to take medication because of stigma. They're afraid to say they're taking medication because of stigma. And it's really, really vital, I think, that we start, because people learn these things from a very young age. So it's so important. And as well as that, it's just workplaces as well as another place to start on. But we are doing a lot better on it. I mean, look, not everyone wants to speak about their mental illness, but look, there are people that do, and obviously I do myself. And what I always find is people are so open to it, and they're so interested in it, genuinely interested in it. So I think education is massive, and I think we really need to keep that on track. And eating disorder in particular as well, awareness, I think really needs to be embedded at every level, because it's just not understood. It's a completely misunderstood illness.
Yeah. And I think that's so important when you've talked about some of the support that, people find outside the health system, when you've talked about stigma and self-perception. How do you feel that sharing the vision can support people who, in terms of identifying people with eating disorders earlier, ensuring people are treated with legitimacy and that they're supported before they actually reach a crisis point? So have you got any kind of thoughts around that, Sean?
Yeah, you probably have to stop me here, because this is one that I will talk about for a long time.
Yeah.
So, look, eating disorders, first of all, they're completely misunderstood. They're not about food, they're not about weight, they're not about what someone looks like. It's about something much, much deeper. It can be about a trauma, it can be about like a lot of things. For me, it was a deep pain, a very deep pain, and I used that eating disorder to help me with that pain. It could have easily been something else. So for me, my eating disorder, I was big into exercise, and obviously I had the food element of it too. Societal narratives about calories, sugar, and all this sort of thing. I'd no idea what calories really were, or the sugar content, but I still bought into it. Read packets. My diet got down to eating the same thing every day. Exercise, I ran every single day of the week. Did marathons. But people would applaud it. Oh, you're doing great. You're an inspiration to your children. Things like that. I wasn't. I was really just doing eating disorder. So to the point, I really think we need to have more awareness in sports clubs, running clubs, all these sort of areas. Again, stigmatizing language. We need to have the tools to spot the signs and symptoms. Schools as well is a place. I know Bodywise do have great programs, but I think we could do great with more funding probably for these programs, to teach teachers about language to use, healthy eating programs as well. Language is massive when it comes to this. Language needs to be reviewed. A standardized policy, a national standardized policy that we're all in tune with, and we all know where we're working from. But again, more funding obviously for campaigns as well is massive. But one thing is GP training is huge, because in fairness to GPs, people always expect GPs to know everything. I did something with the Royal College of Surgeons there recently, and they did a video for a module from the first aid mental health that they're showing to their students, their first year students. But even being able to spot those signs, like we need to be able to spot the signs when healthy is going too far. I mean, I was always told that, I often remember reaching out to people and saying, I don't think I can stop this exercise. And the response was, oh, sure, there's worse things to be addicted to. To be honest with you, I had the same thing. I pulled away from my family. My head was gone, and ultimately it nearly took me away from my family. So it's something that we just so much need to look at. And I think we could manage to get so many people before they get to a point of inpatient care. I needed inpatient care, and I feel if I had got the therapy before that, maybe I wouldn't have needed it. But it's that understanding of where it comes from, that it's not about weight, it's not about what we look like, and there's many different types of eating disorders as well. So Bodywise support will have all that information as well, and we just need to start really looking at it more, because exercise is massive, and a lot of people don't associate with it. So I will stop talking now, because otherwise we'll be still here tomorrow.
And Sean, just finally, that was a really interesting and sort of poignant insight into your own experience. And I think people have found that really valuable. And just kind of looking at your experience of co-producing the Sharing the Vision video, that's my final question for today. But what was your own experience of co-producing this video that we've seen earlier this morning?
It was new. It was challenging for me, because I suppose most of my life I wouldn't have the confidence to do it, first of all. But out of racing thoughts, I wouldn't be able to focus on it. But I think I probably learned more than I probably contributed. I learned so much from my other the two other guys from the panel. So Fiona and Carol, amazing. What they did, like Carol's attention to detail is just so amazing to see and to learn from, and important. And Fiona's creativity Well, I learned so much there as well. And yeah, like watching them and just watching the ideas they had and the things they could see that I couldn't see. I learned so much from that. So my big takeaway from that is it was so good for me as well to be able to use my head, but it was to be able to learn from them, to be honest with you, because they were so amazing. And as I said, I'm not putting my own contribution down. I wouldn't have been as in tune with being able to see all the little bits and pieces. But yeah, no, I did contribute my ways, but I think I learned more from the other two guys who were truly incredible, to be honest.
Well, thank you so much, Sean. I know we've all really benefited from hearing about your own experience and your, engagement with sharing the vision video, and, your insights into the health system and sharing the vision, what it means in terms of stigma as well. So thank you so much. And I'd like to now sort of bring us on to our next speaker. Roshan Farrelly is our Research and Programmes Officer at Mental Health Reform, and Roshan will provide an update on sharing the vision in the voluntary and community sector. So thank you.
Thanks so much, Helen, and thanks to the previous speakers. It was really great hearing your answers, and I'm going to do my best to follow on. And so I've got a presentation to be coming up here. It's fairly brief, and my hope is that I'll be able to add some context onto the role of the community and voluntary sector in sharing the vision, kind of looking at the policy's vision for mental health system and supports in Ireland, and then how that has actually worked in the past 5 years. So we can go on to the next slide. Thank you. I think people watching will already have their own sense already of the role and the importance of the voluntary and community sector in mental health supports in Ireland, both historically and up to the present day. And that can be really, really seen in the fabric of sharing the vision as well, in different ways, through the policy's emphasis on community-based care and early intervention in mental health supports, in application of voluntary and community services to access and provide a link to priority groups within the policy, and then as well in some specific recommendations that have involved partnering between the HSE services and voluntary and community services to achieve what has already been achieved in the past 5 years. So we can go ahead again, thanks. And just looking at the structure of sharing the vision. So it's divided across 4 different domains, and within those domains there are 100 recommendations. Get onto them. There are domains, and throughout the kind of all of these recommendations, there are some core principles that are built in, and some of the ones I wanted to highlight here are that mental health services be community-based. So this is an acknowledgement in sharing the vision of not only the importance of having community mental health services available in a statutory sense, but as well as that in the role of the community and voluntary sector, and that services be available across different regions, that they're not kind of geographically poorly distributed, and as well as that services be informed by communities and culturally aware and culturally competent. And the next principle I wanted to point out here is a stepped care approach. So what we're talking about when we're talking about a stepped care approach is various tiers in terms of mental health supports, going from at a lower level kind of supports and services that are more widely available and that might be accessed by a larger portion of the population, and then moving up kind of in terms of speciality to the kind of supports that are available for smaller portions of the population that require more specialist services. And something sharing the vision talks about, something that really is important and fulfilled within the voluntary and community sector, is the role of early intervention, or those bottom steps, in terms of preventing stress on kind of upstream, more specialist supports by preventing, by intervening early in the lifespan in the course of mental health difficulties. There's really an opportunity then to reduce pressure on kind of more specialist supports down the line. And I just have the next slide here is kind of a visualization of how this looks as per sharing the vision. So this is a population-based model, and it's going from a broad level of service, kind of mental health supports and information that would be available across the population, down to more specialist mental health services that are aimed at people with complex and enduring mental health difficulties. And you'll see that the voluntary and community sector is kind of there in the middle at the same level as primary care. But I'd note that I think the voluntary and community sector really has a role in a lot more of these levels. When we're talking about people going online to seek mental health information about supports that are available, and information about well-being, down through kind of peer support, family care support, up until really there are voluntary and community organisations that really are focused on those specialist conditions or specialist services that are also providing valuable supports there. The next thing to note is, while this population-based model is kind of looking from a general to a specific sense, there are always going to be groups of the population that require different services or that don't fit quite into the services that are available under a population-based model. And sharing the vision conceptualizes these groups through what they call priority groups. So I have the list here on the next slide, please. So priority groups, these are kind of sections of the population that might be at greater risk of mental health difficulties, but as well as that might experience specific barriers to accessing mental health services as they're currently laid out for the general population. And sharing the vision addresses this through specific recommendations that look at partnering with voluntary and community services and providing integrated care through kind of existing, for instance, addiction services or homelessness services and things like that. Go ahead to the next slide. Thank you. That's generally how the voluntary and community sector is embedded in the principles and the models used in sharing the vision. And next up, I just wanted to go into some of the specific recommendations that involve partnerships with voluntary and community services. And go to the next slide. Catherine has already touched on national clinical programs as being quite a core part of sharing the vision. And the idea behind these programs is essentially to examine the kind of evidence and research and come up with models and frameworks of best practice for specific mental health services. So we have listed here like suicidal ideation and self-harm, eating disorders both in children and adults, ADHD in adults, early intervention psychosis, and also there'd be kind of similar national clinical programs for perinatal mental health and neurorehabilitation. And a lot of these national clinical programs from the start are involving the voluntary and community sector, and specifically organizations that would specialize in, for instance, eating disorders or psychosis. And they're really building in what the needs are for these services based on feedback they're hearing from lived experience and from the voluntary and community sector. So for instance, might be kind of individual placement for work or a step care model or things like that. We'll go to the next slide. Thank you. So another kind of key thread we see throughout sharing the vision is the importance of integrating services. This is across a statutory and non-statutory services. So for instance, the kind of single point of access model for children and young people accessing mental health services, and there are various other kind of service integration recommendations in sharing the vision. And one example I just wanted to highlight here is the creation of a kind of directory of voluntary and community services that provide mental health and suicide prevention supports. So this is a kind of an A to Z list that has been developed specifically for staff in community and mental health services, that they would know what VCS services are available to them that they can then link service users in with. And there's been a similar kind of directory developed, but this would be for GPs and specifically looking at suicide prevention under Connecting for Life. And we can go ahead to the next slide. Thanks. I know what the next slide is, it's going to be about safeguarding. So this was a recommendation within Sharing the Vision to expand the services provided for adult safeguarding in the country. So the previous, or I guess existing policy, the 2014 one, would have looked at providing safeguarding for elderly people and people with physical or sensory disabilities. It wouldn't have included mental health services, but Sharing the Vision included a recommendation to expand the scope of the safeguarding policy. And in order to do this, a kind of a new safeguarding policy has to be developed. And I believe that's currently in process, and maybe hopefully soon we'll see that policy. Part of this expansion to mental health services was based on an independent review called the McElroy Report. And I just have a quote here about the basis for which people with mental health difficulties using mental health services would be included in terms of safeguarding, in that mental health problems may not necessarily confer vulnerability, but people using mental health services may be a particular risk, and it's important that they not be excluded from safeguarding. And what this is going to look like in practice is that both statutory and non-statutory mental health services would have access to safeguarding teams, to training, and to awareness to ensure that services are as safe as they possibly can be. And two more slides, I think. Just to call out as well, Sharing the Vision features a whole range of recommendations that kind of created specific partnerships with the voluntary and community sector. And this would be voluntary and community services that focus on mental health specifically, but as well as that, those that focus on, for instance, priority groups or broader services like homelessness, that Sharing the Vision HSEs really recognised are important in terms of integrating and providing accessing those populations in order to provide mental health care in a service that they're already using. So some of these examples here, for instance, people experiencing homelessness, people in direct provision. There have been partnerships in terms of the National Stigma Reduction Programme. The Sharing the Visions involved partnerships with various voluntary and community sectors to assess the needs for more culturally competent mental health supports and how to deliver them, and similar with advocacy supports. And just to finish up then, I have an example on the next slide, thank you so much, of two kind of ground up partnerships, which have already been mentioned before, between the HSE and the voluntary and community sector, that we've really seen coming out of Sharing the Vision, and hopefully we'll see a lot more of as well in the next 5 years, these being social prescribing and solace cafes. So social prescribing, the model is set up to address the social determinants of mental health and the need for people to be connected with their communities during and after having mental health difficulties. And the way this operates is that people will be referred to social prescribing by themselves or by professionals, and they will be connected with a HSE link worker who will then link them in with various local voluntary and community groups. And then solace cafes offer kind of out of hours support that are kind of both a combination of staff and voluntary run. And they also represent this great partnership between the HSE and the voluntary and community sector. So I suppose I've kind of decided to finish the presentation on these two different examples because I think they really illustrate an acknowledgement of the strong role that the voluntary community sector has played and can play in Sharing the Vision and in mental health services more generally. And just kind of we're seeing this in kind of the funding of these programs and the ongoing expansion of, for instance, the solace cafes across the country. Is a really good example. And with that, I'd like to thank you very much. And I'm going to pass the mic to Stephen Donnelly, who is our Communications and Membership Officer, who's going to be hosting a panel discussion now.
Thanks very much, Roisin. Hello, everybody. My name is Stephen Donnelly, and very grateful to be here this morning. And I just want to begin by thanking Helen, the speakers, and Roisin for setting the scene so clearly, looking at both the ambition and the practical reality of Sharing the Vision. And thank you all for being here today. I was looking at the attendees and close to 200 people. I laughed to one of my colleagues the other day that it's about the size of a small Irish village. And in many ways, it is a village. You know, sometimes it takes a village to build a healthy community. So thank you for your participation. I'm delighted to welcome our panel here today, who represent a very broad cross-section of the Irish mental health landscape. So for those speakers, if you'd like to turn on your cameras, so I'll be happy to introduce Grace Carney, who is our National Programme Lead of the Head of Health and Wellbeing at Family Resource Centre National Forum. It's a bit of a mouthful, Grace. Austin Donoghue, very welcome today, who's the Communications and Digital Marketing Manager at MyMind. Joseph Morning is the Head of Learning and Curriculum at Spunout. And then Tasha Lanigan is a Solace Cafe peer support worker and a lived experience expert. Each of our panelists bring a different lens on how sharing the vision is landing on the ground and where it's making a meaningful difference for all of us. So before we start the conversation, and I'm quite conscious of time as well, that if anything comes up for you, if you have any questions whatsoever, please use the Q&A function. You can see it just at the bottom of the bar. Post your questions there, and then we'll allocate 10 minutes at the end of the session to pose the questions to the panelists and indeed to Catherine and Sean as well. So with that in mind, Grace, I can see you there. I guess my first question is, how are you today?
Hello, Stephen. Thank you so much. It's absolutely fabulous to be here. And thank you to Catherine, Roisin, and Sean for setting the scene so wonderfully. As you said, it has made our lives as the panelists to be much easier. So thank you so much. And I'm delighted to be here, and delighted to be here in the capacity of the community and voluntary sector regards the family resource centres. And it's just great to, I suppose, share our experience of how sharing the vision is working on the ground and the impact it's having for our communities. So yeah, it's really interesting.
Can you tell me something about the initiatives and the pilots that the Family Resource Centre are running at the moment to promote prevention, early intervention?
Absolutely. So, Stephen, for those who don't know the Family Resource Centres, there are 126 Family Resource Centres across the country at the minute, soon to increase to 126 at the minute, soon to increase to 136. So we have quite an extensive network across the country, and we are, I suppose, a community development focused organisation where we're really working with the communities, and we're focused with regards to human rights, family support, and that across the lifespan. So right from, our parent and toddler groups right through to older age work. So it's quite extensive, the work that we're doing, but our bread and butter has always been early intervention prevention. Our mental health promotion work has been core to the work that we've been doing, because we are placed in communities and it's within buggy pushing distance for someone. So people know us. People know the staff in family resource centres. They feel very comfortable coming to a family resource centre. So whenever there's initiatives with regards early intervention, prevention, mental health supports, family resource centres are rightly set up to host those supports. So for example, we would have social prescribing services in that Roisin has just so eloquently spoke about. And I suppose the key concept of social prescribing is starting where people are at. It's about what matters to a person, and not what is the matter with the person, what matters to them, and how can we link them in with the communities? Because we know from the community and voluntary sector that communities have the answer. Communities know themselves, they're so resilient. And when something goes on in the community, people can rally around once you're part of that community. So having services that are outside of the community, so people traveling, for instance, 20 minutes, half an hour to 2 hours for a service, we know traditionally that this isn't working, that people they don't feel like they belong in that service. Regards social prescribing, our link workers are based in the Family Resource Centre. So that means they then have automatic access to our community development workers, our family support workers, our old age workers, if we have them present in the centre. But we also have huge knowledge. Our boards of management come from the community, so they know, they know what's going on in a community. You're not trying to research and find out, is there a running group? Because the people in the Family Resource Centre, they know that there's a walking group, or perhaps the knitting group is involved in the Family Resource Centre. So we have that experience on the ground of linking people in. So our social prescribing link workers who are based in the centres, they already have this really rich knowledge. So they're not starting off being like, God, I wonder where can I link someone in? All they have to do is ask someone else in the centre, you know, get up to speed with regards to knowledge. But so often the people who are accessing the service, about 80% last year, were self-referrals. So that's just showing the trust that they have in the Family Resource Centre, that they'll come knock at the door, say, do you know what? I need a little bit of support right now. And we all need that support at some point of life. But it's a case of they're familiar at the Family Resource Centre because they may have went to the parent and toddler group with their kid, or they may have been part of the knitting group where granny is involved in something or their child's involved in one of the sessional camps. So they're like, do you know what? I can knock down to the Family Resource Centre and ask, is there anything that can support me right now? And then we're in a position to be able to provide that support. So we have, you know, from the non-clinical, non-judgmental supports at everyday level, and that's exactly what the social scribing services. It's that starting where those people are at right now. And then there may be an instance of where we may need to escalate them to more clinical supports with regards. Some FRCs are providing therapeutic supports, and then we can link them into our therapeutic supports, or perhaps escalate that if there's more statutory services needed for that person. But so often the social scribing can be that starting point for someone. And indeed, for a lot of people, they're just then linked on and they find their feet or their wings basically, and they can just integrate into their community and find that support network themselves.
Yeah, it sounds like the first domino in many that it can just unlock so much more potential in people. So thank you very much for that, Grace. And maybe moving from the traditional physical environment to the online one, maybe I could ask Joseph if you would be able to tell me something a little more about Spun Out and the work that you do. It's like Spun Out has invested heavily in trusted digital tools like the Navigator app released last year and the Academy platform to help young people find reliable, trusted information. From your perspective now, Joseph, how can digital platforms like yours realistically bridge any gap between young people and formal services, especially when trust is such a big issue there and confidence?
Sure. Well, I suppose at Spun Out, we've been working in these kind of digital spaces for about 20 years now. The internet has changed a lot in that time. It's definitely become, for a lot of young people, the first port of call, the first place they'll go for information or support for their mental health. And in a lot of ways, that's understandable. There are reasons for that. So young people like that it's immediate, you know, the internet doesn't have any opening hours. You can access it anytime. Also, it puts you in control. You can choose what information you engage with, how you engage with it. You can pick what is either relevant or not relevant to you. And for young people, that autonomy is really important. So it makes sense. I think a lot of people have an initial kind of fear reaction with this idea of young people accessing information support on mental health online. Misinformation and disinformation spring to mind. I think we all have a good understanding of the risks that come with that. But actually, something that we don't talk about as much is the risks that can come with accessing accurate information that is incomplete or out of context or applied inappropriately to your own situation or your own circumstances. So while yes, at Spun Out, we're kind of first and foremost a trusted source of information for young people, we also knew that we needed tools that would help them navigate that information and find ways to apply it in their lives safely. You know, so that's where tools like Academy and Navigator came from, was that idea of the extra support that wraps around the information. I think as well, it's really important to keep in mind that for a lot of people, if they're, you know, if they're turning to online sources of information and support, it's often the first step, you know, so it works with, as you say, the kind of trusted statutory supports. You know, that's another step in the kind of in the support journey and the recovery journey. And sometimes people will go back and forth, and it can lower a lot of the barriers that are holding young people back from accessing this support. So it can do that by showing young people what supports are available to them, what's out there, and the steps that they can take to access those supports. But also, a really important one is we can help young people see what it feels like to access these supports, what recovery might look like. And we can do that through sharing other young people's stories on our platform. So it's a huge part of what we do. But the piece that's still missing, the thing to make this kind of like funnel of support access work really, really well, those supports on the other end, they need to be accessible, they need to be effective, and they need to be adapted to young people's needs. And the only way that can happen is if they're actually informed by young people's voices. So that's why it was great to hear so much conversation so far today around that kind of service user involvement in kind of building these services.
Yeah, and that to sum it up, maybe in co-creation as well, is just such a powerful asset that Spun has been able to deliver, and it feels like very baked into the DNA of your organization. How's that working?
It is. It's kind of sometimes it feels hard to describe exactly how integrated that kind of youth consultation and co-creation is in the work that we do. But I think a good way to describe it, and I always kind of come back to this, is if the young people that we engage with, if they disappeared tomorrow and weren't engaging with us, all the work that we do would immediately grind to a halt. So we wouldn't be able to do anything without them. And that's because we set ourselves up in that way. So we say that we're for young people by young people. And, that kind of youth participation is at the center of everything. It's before we start a project, before we write a new article, before we build a new tool, it starts with youth consultation. So we have youth action panels across the country, about 200 young people in those. And throughout the year, we're engaging in like ongoing consultation with them. We also have a wider network of volunteers, some of whom will kind of like review any content before it goes live on the site. So they'll review social media posts, articles, videos, things like that. We also have young people who will submit their own lived experience, so they'll write articles or they'll make videos, they'll feature in our kind of social media content. We also have sometimes we'll need kind of like broader input. So we'll pay attention to kind of like digital media trends. We'll look at what young people are searching for online. We'll look at what they're talking about on social media. We're kind of trying to keep our ear to the ground with that as well. And then sometimes we'll run online surveys if we want to cast a wider net, if we want to capture those voices that maybe aren't represented on our networks. So it's an ongoing process. We have a dedicated team in-house who just do youth participation. It's their whole thing. They work really well. We have two young people who sit on our board of directors. And they're kind of like equal board of directors compared to everyone else who's there. They have equal say, equal impact. So there is kind of it's really baked in to everything that we do, and we couldn't do what we do without it. So I think sometimes it really shows up if you want to avoid kind of tokenism, things like that. It's good to look at, have you ever had to make a difficult decision, because of feedback that you're getting from consultation? So we have, sometimes we have an article has missed its deadline because we haven't had a chance for a young person to, they haven't had time to review it yet. Sometimes we had a social media post that was ready to go out, but based on feedback, we had to pause it and go back to the drawing board and change it. It really does kind of supersede everything else, that we do, is that kind of like youth input. But it means that we're able to produce things that we just could not produce without that input, I think. And what I've learned from just that process and kind of being in Spun Out for a number of years now is, first of all, young people can spot tokenism a mile away. They're really tuned into it. And the more that you kind of like build trust and you can show that the effort that they're putting into, sharing their opinions is turning into real change, then the quality of consultation that you get improves as you kind of build that trust. But it doesn't happen overnight, it's a process. But to be able to see how a project can grow from, if you involve the people it's for from the beginning to the end, like it's really exciting.
Yeah, it sounds magic, and it sounds like you really understand the cohort. Like kids often feel overlooked and dismissed, or we will give you some autonomy now as well. But really, like, slow down and make yourself think: why do we have this time frame, this deadline in place? Is it to suit us, or is it to suit the people that we're representing? So, yeah, very eloquently said. Thank you so much, Joseph. And you mentioned something about accessibility, which is a lovely segue to Austin, because it got me thinking about like sharing the vision's need for mental health services to be accessible and responsive. Austin, as part of my mind, when you talk about accessibility, what does that actually mean in practice, and how does it influence in the way you design and deliver services?
Hi, Stephen, and everybody else. Thanks so much for the invitation this morning. Just want to say absolutely delighted to be here. So yeah, the accessibility aspect with My Mind, for anybody unfamiliar with My Mind, we are an early intervention for mild to moderate service. We offer professional, accessible counseling and psychotherapy to, as the mission statement says, anyone experiencing mild to moderate mental health challenges. So ease of access then is really a cornerstone of our day-to-day work. It does also, of course, align with sharing division and domain 2 with the goals for service access. So since 2006, we've been working to increase access to affordable, accessible therapy within the mild to moderate early intervention context. And we work on multiple fronts to make the service accessible. Clients can self-refer. We're a self-referral service. They can book an appointment within 72 hours of registration. So we aim to make it as timely as possible in that way. We don't have waiting lists. We have a large network of mental health professionals and good capacity in terms of the 72-hour kind of aim in terms of the nearest available appointment. We have 11 physical locations across Ireland, so face-to-face counselling and psychotherapy, but also online as well from really any location within Ireland. I suppose we're also a social enterprise as well as a registered charity. So our services do carry a fee, but those fees are tied to income status. So, kind of tackling it from that side as well, we offer low cost counselling at €30 per session to a wide enough cohort of individuals, anyone earning under €25,000 per year, full-time third level students, retirees, the unwaged. So also, of course, including some priority groups within that in terms of the third level students, state pension recipients. And then on top, there are free supports. We currently have a men's mental health initiative. We offer free support to displaced Ukrainians living in Ireland, and also residents affected by defective concrete blocks in 6 counties across the West Coast, with face-to-face counselling available in our Ballina and Ballinrobe locations for that as well, both in Mayo. And then from there, it's about making everything flexible as possible. So as I said, the sessions can be online, they can be face-to-face. Clients are free to obviously kind of mix and match as suits them on their day-to-day. It's really about kind of meeting people where they are. And within that kind of large network of mental health professionals, there are over 20 languages spoken as well. And behind all that, there's an office team who are, always there to answer queries from clients, to kind of help them select a therapist, to explain some of the specializations. We have cognitive behavioral therapy, we have art therapy, we have a good range in terms of different specializations. And then a developer team behind the scenes, just trying to make the user experience kind of as smooth as possible. There's a tech aspect with the online counseling and all of that as well. So yeah, just making things smooth and accessible is kind of right there and baked in to the organization.
So short answer, it's very accessible.
We endeavor.
Yeah, that's amazing, Austin. And looking back in September, mental health reform, we were delighted with the announcement from Minister for Mental Health, Mary Butler, about the allocation of €2 million for talk therapy specifically for men and men's counselling. Can you maybe expand a little bit upon that and how that has been developing for you since September? Thanks.
Sure thing. Yeah. So yeah, the Men's Mental Health Initiative, something that we're massively grateful, of course, to be kind of entrusted with. So, would like to thank the HSE and Minister Butler for their faith in my mind. I suppose for the Men's Mental Health Initiative, it's unique for us in that it's done exclusively through GP signposting, where ordinarily we're a self-referral service. And there's a good logic built into that, which I suppose if I explain how it all works, might make a little bit more sense. So the project's been ongoing since September. We will be providing 5,000 free counselling and psychotherapy appointments to men experiencing mild to moderate mental health challenges over the course of, that was the end of 2025 into 2026. It's continuing into this year. So it started with a big mail out campaign to over 1,400 GP practices. We sent them a cover letter and promotional cards with instructions and a QR code to hand to male patients when they're presenting with issues outside of mental health. So, and I suppose it speaks to this kind of seeing the signs aspect of the conversation earlier. But, if we think of kind of the young father, young professional suffering from burnout, showing those kind of early signs of kind of low mood, persistent tiredness, irritability, and not knowing themselves even that they could be mental health related. The aim is that the doctor, the GP, hand over the promotional card for that, and that in so doing, we're kind of broadening out the service and increasing awareness for the service to people who wouldn't have ordinarily or otherwise engaged in talk therapy. Within that, then the full host, the full range of My Mind services is, of course, covered. It's cognitive behavioral therapy, art therapy, counseling, and psychotherapy. As I mentioned, we do advocate for early intervention for mild to moderate mental health challenges. So very much in line with that as well. I think it's a good fit in that sense. And clients really do come to us for a host of kind of what I guess we call everyday mental health challenges. So, burnout, relationship issues, things like that can become the seeds and can be the seeds of further issues down the line. And that's something that we strongly advocate for, that people do seek support early. And we exist to try and, have the capacity there for that.
Yeah, I'm doing a great job. Thank you so much, Austin. I wonder if we could pass the microphone to Natasha. Tasha, it's good to see you. Sharing the vision, Tasha, it hinges on lived experience on paper, and you are playing a role in that through your work as a Solace Cafe peer support worker in the newly established cafe down in Waterford. So I'd love to know if you could share a little bit about yourself, your story, if you're comfortable with, and how that is informing your work today.
Yeah, thank you, Stephen, for inviting me to talk. I'm really grateful to be here and to share my insights. So yeah, I'm going to talk a little bit about my lived experience. It's a little bit of just to give a warning. It can be a bit traumatic to listen to, but I just want to give that perspective of where I'm coming from. So when I was 13, I lost my mum to suicide, and as you can imagine, that's very traumatic. And I'm not here to talk about HUG, but I have to briefly mention that I'm a facilitator for HUG, and that's been a great support for me in recent years. But I have a lot of mental health experience in the Department of Psychiatry, both in the UK and in Ireland. I've been in subacute and acute wards. In my early 20s, I presented with psychosis and then also ideation of suicide and attempts on my life. So after after a long period of time, I did recover, and I did lead actually quite a stable life for quite a while. But then in my late 30s, I moved over to Ireland, and about 5 or 6 years after living in here, everything resurfaced again for me. So in the last 10 years here, I've been in and out. I've had psychotic episodes, I've had ideation, I've had attempts. So it's been a very traumatic journey for me in terms of mental health. But I wanted to just set the scene for where I'm coming from and what I'm about to talk to you about. And the fact that now, thankfully, I have, really good supports. And, I kind of, my journey has been one where I found good psychotherapy and mindful meditation. And actually, one of the major things, a good thing that's helped my recovery is a consistent psychiatrist over the last 10 years who knows me well, who understands me, and who's listened to me. And I know that, from speaking to other people, that that's quite rare. And I feel incredibly lucky that I have that consistency because he's been brilliant and he's really got to know me. And what I talk about as well is not that medication isn't we are a medication-led model, and medication is important in mental health. And like Sean was saying earlier about stigmatization, it's not about whether we have medication models or whether we don't. It's about, combining services. And this is what I see Sharing the Vision doing, is about pulling services together. But before I go on to that, I want to talk a little bit about what I've seen on the ground. Obviously, I've been in acute wards and subacute wards in the Department of Psychiatry and in the DOP. 10 years ago, it wasn't where it is today. It was quite a traumatic experience for people, for me especially. And I can see the difference. I can actually see the difference in patient care. I can see, in my last inpatient stay, I can see the change in the staff. I can see the training is making a difference. I can see compassion. I can see a lot of changes over the years that's making a huge difference to patient care and to my care. In fact, my last experience was way more positive, and I can see the changes within services in terms of the supports within inpatient services, as well as just people aren't just left to just kind of get on with it, especially in the subacute wards and stuff like that. So I wanted to feed back that these impacts, the Sharing the Vision changes, they are having changes that you can see visibly on the ground. But the tools that I've had are to keep me well have been like I said, a mix of things. I've had medication models, but also CBT, mindfulness, sea swimming, meditation, and things like that. And what I wanted to talk to you now about is the Solace Cafe. So the Solace Cafe is exactly what I imagined it would be. It's a brand new service for Waterford. We're only on the ground since November, and we're still relatively new. But it's for me, I've got a lot of experience in crisis support and crisis myself. So being able to see how we can support people in crisis through the Solace Cafe is brilliant. People can come in, they can sit down, and they can be listened to. It offers a real alternative to the emergency department environments, and it'll be different things for different people. Some people, they just want to come in and have a chat and be listened to. And this is the space that we're offering them is somewhere where they can be seen and where they can be heard. And given that space to speak there, to let their problems, actually be heard by the peer connectors and stuff like that. And you can see people visibly changing. You can see people relaxing, and they're coming in with quite a lot of tension, but you can see people actually relaxing and connecting with you. A lot of people are very isolated, and a lot of the time we're seeing people that are very lonely and don't have those supports and stuff like that. So being able to support them in a compassionate way in a nice environment. ED is not the best place for people to go. And, if we can keep people out of ED or keep people, obviously emergency departments have their place, and definitely, I don't, I'm not saying that they're a bad place for people that are in crisis, that they definitely have their place. But there are situations where people don't need to be there. They just need to be listened to, heard, seen, talk through their problems, and get the correct signposting for them. They don't necessarily need that huge level of escalation that comes with ED. Often that's the scary part for people in crisis, being able to actually calm things down and offer people, an alternative, which is, a lot calmer. And if people do need ED support through Solace, then the cafes, then we can do that for them. They can come to us. But for the most part, we're trying to look at what we can do outside of that, and in combination with the crisis teams as well. That I think this definitely provides a definite another alternative route for people. Yeah.
Thanks very much, Tasha. I mean, you just consider like the lonely space between GP care and ED emergency departments, where you're in no man's land, and it can be a lonely place. But like the Solace Cafe has, it's provided that environment for someone to go to. So thank you so much for sharing, and for sharing your own experience as well. To be honest, I could chat with you all day, but we are under time, so I'm going to be cheeky now, and we will get to answer some questions from our audience, and thank you for submitting them. But just a quick 10-second, one-word answer. We use this in therapy. So imagine 5 years from now, sharing division has concluded. What was the opportunity or development that meant the most for mental health in Ireland? Grace?
For me, it will be the partnership approach. Okay. Between community voluntary, statutory agencies and communities themselves, because that is the answer, and we need it resourced properly.
Okay, thanks. Joseph?
Very similar. Yeah, co-working. I think very or mental health support systems very complex, but it shouldn't feel complex to a user, So I think it should feel like one cohesive experience, even if you're moving from one service to another, or you have multiple services involved in your care. And I think really good co-working can make that possible.
Okay, thanks. Austin, would you have an idea?
Sure. So I suppose wearing my communications and marketing hat, always thinking about public perception. So I guess just increased understanding that's happening in our society of mental health being part of overall health. Minister Butler often says there's no health without mental health. And I think from a kind of that communications perspective, that's a really powerful framing, really powerful way of kind of telling people that mental health is for everyone, and that, it's not just when there are serious challenges. So yeah, I think just the mental health within the context of overall health, increased understanding there is a big power for change.
Thanks, Austin. And last but not least, Tasha, the final word.
Yeah, for me, it's holistic mental health recovery. I want to see, a proper holistic program where, we're not just looking at a medication model, which is very important for patients with mental health, and certainly in acute situations. But we're looking at other, usable alternative models. And particularly, we're drawing on, I have to mention this, the East, and harnessing your mind, mental awareness, and being able to really use those tools in conjunction, because that's where I see the power and the benefit of mental health recovery.
Thank you. And thank you all for all your expertise, for looking at the same thing from different perspectives. Really allows us to see the whole thing for what it's worth. So I really appreciate it. And with that, we can look at maybe some questions and open it up to the floor. There was a question here from a viewer who was asking, this would be more directed to Sean, and thanks for his share. When you're talking about education, is the support system available in secondary schools?
Yeah, but like Bodywise have released a program recently, and they do work in secondary schools. I know they have a program that they've updated it recently, I think. So I don't do a massive amount of awareness work Bodywise, but if you check their website or you contact them, they have all the information. But I know they did do a promotion recently on an updated model. So They have great information as well for body image and what eating disorders are about and stuff like that. So it's always worth a look.
Great, thank you. Super. I'm moving on. This would be for the group maybe. How can we help minority groups understand and access mental health services without necessarily feeling ashamed or stigmatized?
I suppose from Spun Out's perspective, one of the things that we try and do is to platform the voices of people from minority groups, so just creating a space where whether it's through an article, through a video or something like that, young people who are coming from minority backgrounds are able to talk about their experiences of accessing these supports and some of the just like unique barriers and challenges that they face, whether it was through like cultural expectations, through challenges kind of within their own family, things like that, So there's no easy solutions to these things, and those kind of changes take time and it takes support. But I think it happens a lot of the time through conversation, So there are things that the services themselves can do to be kind of culturally aware, culturally sensitive. But I think there's also that conversation piece that can be really transformative.
Okay, thank you, Joseph. I'm conscious of the time as I sound like a parrot now, but what we can do is to thank everybody for the questions that have been submitted. I can prepare an FAQ document so we can maybe put these to the panel after the webinar has concluded, because some of the questions are very interesting, but maybe quite in depth and involved. So I just want to thank you for people who've contributed. They will not go unnoticed. And also there was an awful lot, I would imagine, positive feedback and support for you, Natasha. So I'm always delighted to be able to hear your story. So thank you for bringing that impact. So I think that is my part, and maybe I could thank you all again, and I'll pass over to Helen for some closing remarks. Thanks.
As we come to the end of today's session, I'd just like to thank all of our speakers, our panel members and participants for your insight, your honesty and commitment, and to thank you for each of your engagement and contributions. We had some really interesting discussions and perceptions today that are very important for going forward. And what we've heard this morning really highlights some of the progress made under sharing the vision, but also the importance of the next phase in implementation as well. We've seen how voluntary and community organisations are driving change, how peer-led supports are reshaping recovery, and how collaboration across sectors is essential for a mental health system that's responsive and person-centred. And we've also acknowledged the importance of people with lived experience in shaping, designing, and leading on implementation. There are challenges that remain, but these also create opportunities for deeper collaboration and innovation as well. The 2025-2027 implementation plan will be pivotal in strengthening community-based supports guided by meaningful leadership from people with lived experience and a shared belief that mental health support should be timely, compassionate, and rooted in our communities. And just finally, there is a reminder that you can find out more about our work on our website, mentalhealthreform.ie. Our new Sharing the Vision videos are available to view on our website and on YouTube. And thank you again for your time, your expertise, and your ongoing commitment to improving mental health services in Ireland. Thank you.